Okay, I'm really specific. I'm an educator of first and second graders, and my question is for Dr. Hagerman. Math is a really difficult subject to be teaching to girls with Fragile X, and I've read a little bit about interventions. Is there resources that have, you know, when you're solving math problems, you're doing one-to-one correspondence and that's not working, is there resources of methods we can use in addition to what we have provided in our school?
Yeah, there are. Marcia Braden developed a math educational program specifically designed to help individuals with Fragile X learn math, and she has a website. It's marcia.braden, and Braden, and she actually is in Colorado Springs, and I'm trying to think, I think if you Google her name, it can get you to the site, and I think that the National Fragile X Foundation also has it on their list of materials available. So that fragilex.org website has, it's a big website, but they do have a page that has resources and, you know.
Is it better to start big picture with kids, you know, when you're solving a math problem, or is it better to wait till they actually...
Could you speak in the microphone? I'm sorry. Could you repeat that for the microphone?
I can usually speak pretty loud, but is it better to start, I mean, you know, like you're solving a math problem and it's too difficult for them. Do you wait till they can do one-to-one correspondence before you move to the next thing? Or do you just keep giving them experiences until they get big picture? My student I'm thinking of for reading, I just keep giving her things even though she hasn't quite gotten it yet and she's excelling. And I'm wondering if I should do that for math.
Oh yeah, I think you try to present it in a lot of different ways and use every kind of thing that's available. You know, the strength for kids with Fragile X has to do with that visual pathway that is just static visual pictures too. And so different visual things like that, you know, the touch math approach, you know, where you put dots on different parts of the numbers and stuff. That's real good. Any kind of visual presentation to show concepts and equivalents and stuff, putting it in visual terms as much as you can, or concrete terms. That's a great way to do it. And, you know, there's a lot of concepts that I think that, you know, they will never get. And so, you know, using, you know, calculators and other sorts of things is good. I think the assistive technology software, and I guess Math Blaster, and there's a lot of different programs. I would use a variety of, you know, special education math programs too, because they're really good with visuals. So I would use any and all approaches.
I love Math Blaster.
Yeah.
Those can also be used as rewards for kids like who earn computer time. I had kids who actually did Math Blaster and didn't realize that their reward was actually math. So.
Yeah. And, you know, there's a lot of different disorders that have math deficits associated with them. I mean, it's not just Fragile X, Turner syndrome, velocardiofacial, many different neurogenetic disorders have math problems associated with it. And we work with a psychologist, Tony Simon, who does a lot of work with velocardiofacial and Fragile X, and he's developing some early computer games that can be utilized because he thinks it's very much related to the visual spatial development in the brain, and he's developing early computer programs that he thinks will help the development of math concepts.
Are those basically arithmetic, or are those, you know, bigger like problem solving or geometry, all of those things, or is it more, should I focus on arithmetic?
Yeah, yeah. I think some higher math and algebra and stuff are just basically impossible for many of these kids. So we're just talking about basic arithmetic here.
First grade now. In basic math, we teach algebra in first grade and all of those things. So I'm just wondering how high to reach for her.
Yeah.
Yeah.
Uh,
I think a lot of math programs, is it a spiral math program where you're touching on the different, those I think are really hard for most kids with disabilities, and you just have to go to an alternative curriculum.
We have a question from Greater Minnesota.
Yes, this is a question from Rochester. Where does a family go for genetic testing? Is there a lab that can do Fragile X blood spot testing?
Actually, the Fragile X blood spot testing was published last year in a paper in Journal of Molecular Diagnostics by Flor Tassoni, who's actually at our center. We do the blood spot testing related to research, but other labs are learning blood spot testing, and we definitely want a lab here that could learn the blood spot testing. It'll be for research screening. For the clinical available diagnostic testing, it's a peripheral blood draw. It can be ordered through any physician. Any physician can order the Fragile X DNA test. Most university laboratories do Fragile X DNA testing. There's a lot of commercial labs like Genzyme and Athena Laboratory Diagnostics that also do it. So most of the commercial labs will all do Fragile X DNA testing. So any physician can order it. Every person who orders it, it will get sent off, like if you're at a clinic or at a university, it'll be sent off to be done where it is contracted for. So it may be done at the local university lab or through a commercial lab, depending on where the contract is done. One of the least expensive places, most places charge between $200 and $400 for this, but it's covered by insurance companies. The laboratory, Sally Nolan's laboratory at New York State, Department of Developmental Disabilities, Ted Brown's Institute in Staten Island, used to do it at no charge, and now they charge a minimal fee. But if there is a problem in getting it locally, it could be sent to that New York State lab, which is probably the least expensive.
We routinely, for kids that we see, if we want to order Fragile X clinical testing, they often just get the blood drawn before they leave the appointment through the pediatric clinic, and I'd imagine Mayo Clinic has.
Yeah, Mayo has a lab that does it, and a lot of commercial labs do it.
Now, is that going to be the same, though? Will you be able to see the pre-mutation?
You mean so the blood spot test is a very inexpensive test used for very large population screens like high-risk groups. And that is available for laboratories that want to learn how to do it. If the blood spot is positive, then it's confirmed by a follow-up clinical test. So say if you're doing newborn screening, or say if you wanted to do the blood spot test here and it's developed by one of the laboratories here, and that would be a research study maybe to look at everybody with a certain diagnosis or whatever to see how many are positive for Fragile X. Then it'll be followed up. If that's a research project, then it'll be followed up by the clinical DNA test.
We have I'm sorry, I want to be clear that the microphone is not so people here can hear you, but so that people elsewhere can.
Okay. I have a question that I have 2 kids with Fragile X, and a lot of times they fall under the Autism Spectrum Disorder diagnosis. But in what ways would you say that it's different than autism to help sort of differentiate them? Because I know some of the ways that's similar, but are there ways we should know that it is different?
Well, so about 50% will come under the autism spectrum. The ones that don't come under the autism spectrum are much more interested in social interaction. So they're not only interested, but they're much better with their social interactional abilities. They can still have a lot of autistic-like features like hand flapping, poor eye contact, perseverative speech, etc. But the key that makes them not in the ASD spectrum is their interest and enthusiasm for social interaction and their language abilities. So it's just a very intrinsic key aspect about social and interactions and language that makes them not qualify for the autism spectrum. So all of these autistic-like features, it doesn't make any difference how much autistic-like features you have. It's really these core deficits in social interaction and language that differentiate them from the ones with autism.
Do we have more Greater Minnesota questions?
Yes. This is a question from Rochester. You stated genetic testing is essential. Essential to whom? Researchers, parents? Genetic testing is expensive, and a family's insurance either may or may not pay for it, or the copayment is extremely expensive. While it's clear that research is important, can researchers offer genetic testing at no or minimal cost?
Yeah. I think that knowing the genetic etiology for the cause of their autism is essential for family members, essential to guide the therapy for the child. And if this child is part of a research study, it's of course very important for the researchers too. So I think it's important for all. It's out there in the medical literature that genetic testing is medically indicated and is a necessity in the workup of the child for autism. So if an insurance company denies it, you can fight that. It's a medical necessity. So it is, something that they're liable for if they deny it. And so that's why most insurance companies will cover genetic testing for autism. Depending on what type of test that's used, it can be very expensive. The Fragile X DNA test is cheap. The FISH studies with high-resolution chromosomes are more expensive, and the CGH array are the most expensive. And that last one that actually demonstrates these subtle deletions and duplications, that is the one that may not be covered by some insurance companies, although that's starting to be covered more and more because it's a very valuable type of testing.
And to answer about research studies, there are, you can go, is it the Ian one is, it's not Ian, it's Isaac, right? Or not Isaac, it's Ian. I think there's an Ian website that you go on, IAN, and that can tell you about research studies available in your area that you might be involved in. A lot of researchers in autism put their studies up there as kind of like a flyer or an advertisement for involvement. I've consulted on genetic studies, and one of the things that you should be aware of is it might not be the genetic test that you're looking for. So if you want a specific type of testing, you need to know enough about genetics to know what they're looking at. Another thing is, it's not like going to the clinic. Your blood gets sent, but who knows when you're going to get the results back. It's not pressing because it's for research, not for clinic treatment. And a lot of the families I know have called us back for our study saying, what were the results? And we aren't always able to give those results. So you should ask questions as part of research studies, like, will I find out if there is something abnormal? How will I find out? When will I find out? Are you doing testing that will enable me to see Fragile X, et cetera?
Yeah, and our Fragile X testing that we do in all of our studies is always covered. So we not only look at CGG repeat, but we look at messenger RNA levels and protein levels and X activation ratios. So we look very carefully at the Fragile X gene, and it's always covered in our research.
I have a question regarding medications, if Dr. Hagerman wouldn't mind addressing. My young adult son he has tried a few different medications through the course of his 20 plus years, and he's had adverse side effects. And when I bring up Abilify to two different physicians thus far, they're not comfortable with it and don't want to pursue that angle. And what my son has tried in the past is a stimulant drug like the Ritalin and then the SSRI. He's had some adverse effects as emotional outbursts and irritability, so then we've backed off. And now we're trying the guanfacine, just a low dose. It's only been a month, and we're not quite sure yet if we're seeing positive effects. But I walked in just as you're introducing yourself and talking a little bit about some of the background medications that have found to be efficacious. Would you mind addressing?
Sure. I also have a paper out in January of pediatrics. So if your physician wants to read about the latest medications, the January issue in Pediatrics has an article about advances in Fragile X treatment. So it goes over all of the research done on a variety of medications. I think Abilify is basically the best medication out there for Fragile X, and that may be true for some subgroups of autism too. But Abilify has some remarkable effects. I think if you have a physician that's uncomfortable with Abilify, you could probably go to a specialist that is comfortable with Abilify. You have to go with very low doses because sometimes if you give too high of a dose of Abilify, like for adult, I would start with 5 milligrams, and if they have agitation, that means you always cut the dose in half. And so there's a lot of individuals, that are just on 1 or 2 milligrams of Abilify, and it really has some great effects about improving attention and concentration because it enhances dopamine frontally, decreases anxiety, but it's a great mood stabilizer. It's kind of a new version of Risperdal or Risperidone. And risperidone has been shown to be very efficacious in autism. I mean, this came out in New England Journal of Medicine in 2002, that risperidone was helpful for 68% of individuals with autism in terms of decreasing a lot of negative behaviors like aggression or outbursts, improving hyperactivity, making a big difference in terms of some of the repetitive behaviors. I think that's very helpful too. I think it's very exciting about what serotonin agents can do to improve language and socialization. So these are core features of autism. And I think a young kid with autism who particularly has a low language or has obsessive compulsive behavior, which SSRIs do a lot for. I mean, I think that kid should definitely be tried on an SSRI, and there are big multi-center studies going on now. There's a variety of different studies that have demonstrated efficacy with SSRIs in autism and even in preschoolers. So, I mean, I think that these drugs can be quite helpful early on. And of course, whenever we're talking about medication, we're also always talking about multimodality interventions. So all of the stuff that Amy talked about are critically important. But I think you also have to get the medical input to really understand the specific etiology of autism through genetic testing, and also have the advantage of trying some psychopharmacological interventions. And that's even more true of targeted treatments. Should your adult try minocycline? Good idea.
I had a question about your report on the evidence base for behavioral treatments. You said that the evidence showed that 25 hours a week was sort of the minimal, optimal, or required level of dosage. What I wasn't clear about is that 25 hours provided by professionals, or is that 25 hours of certain types of activities, regardless whether it's parents or professionals?
That's a really good question, and I don't think we know the answer to that yet. There have been, the 25 hours a week really came from, what is a full school day? So that's where they kind of started from. And then there were some studies demonstrating research support or evidence that once you hit 25 hours or more than that, you see significant, effect sizes or gains in skills for kids. But if it's less than that, 10 to 20, you don't see as much or you don't see any. So that kind of came out of also a lot of these programs say you have to have 40 hours a week of therapy before you see effects. Well, really the research doesn't support that. Or, 25 to 40 is kind of equivalent, but you do have to get to a certain level. Now, there have been studies that have looked at parent-implemented therapies like doing ABA as opposed to, a UCLA-trained professional. And there's always a little bit of drift, and it seems like less efficacy when you compare community-implemented interventions to ones that are done under highly controlled conditions. But what you have to sort of remember is these are kind of different populations. So the ones who get to UCLA, by the way, Jenny McCarthy's child, those are sort of the more educated, they have a little bit more resources to take the child to that highly controlled environment, and it's just different when you're covering everyone. So I think, these are basic guidelines, and we need to do the research to know for whom these interventions work and what the sort of dosage is for each kid. Certainly parents and community people who aren't PhDs in autism can do these interventions and show treatment gains for the kids.
This question is for Amy, and could you clarify Weatherby's program, spell it for me, and compare it just briefly with Dawson and Rogers?
Okay, say that first part again.
What is Weatherby's program called, and then how do those two new programs compare, just briefly? Sure.
So Amy Weatherby's program is called Early Social Interaction, ESI. You can find out a little bit about that on the Florida State University website or Google Amy Weatherby. There's also a study on that going on at the University of Michigan. So that's their replication site. That's a brand new treatment. There isn't, recently got funded to have a multi-site study to see if it's working outside of the initial kids who got the intervention. The difference between that and Sally Rogers, Jerry Dawson's Early Start Denver model is, I think the intensity is different. So, and this, let me just tell you, this comes from talking with Kathy Lord, so this isn't in any research. Kathy Lord's group is implementing both interventions at the University of Michigan Autism Program. So the Denver model has, more kind of instructional, scripted emphasis on things like imitation, and skills like joint attention, whereas the early social interaction interventions look more like incorporating communication strategies within what you're already doing. So I know that they ask parents to identify one daily routine, like giving your child a bath or eating or getting dressed, and working in some strategies to get more spontaneous communication at those times. And you also do like a set-aside play time with your child where you're sort of tutored by a consultant who helps you build that play interaction. And so also these therapies kind of have different purposes. So Early Start Denver model is really for kids who are diagnosed already. So like right after they get diagnosed, they're 2, they're 3. The early social intervention model might be more geared toward kids who are showing some signs, or they might be at risk because they're baby SIBs, but they don't have the full diagnosis yet. So I don't think we know like which kid would do better from which intervention or how those two compare to one another, but hopefully that information will be coming soon. There are studies funded to look at those things.
I'm getting the sign that we've run out of time, so I want to thank our distinguished speakers for a very interesting afternoon or morning. Thank our attendees for being here.